one size does not fit all, and really you have to adjust your therapy for any individual patient accordingly. So with COPD, it's nice to have a set of guidelines to work from, and the most commonly used ones, the ones that are most validated, are the GOLD guidelines, which I think everybody's sort of familiar with. If somebody's just mild, has just mild amount of symptoms, and they have a reasonably good FEV1, we just use the as-needed inhalers. And those are things like the beta agonists and the anticholinergic drugs, albuterol and ipratropium. Those are the two medications that are most commonly used. Just about everybody is on them who has COPD. Sometimes they're used in combination as well. If you have moderate disease, so now you've gotten a little bit more symptomatic, the FEV1 has dropped a bit, you're under 80%, down to about 50% on the FEV1, you have to add in a controller medication. And a controller means something that's long-acting, that's going to be on board in the system, that will work throughout the day. They can still use their rescue medication, that's the albuterol or ipratropium, but they got to have something on board. In COPD, it really is different than what we do for asthma. In an asthmatic, the first controller medication you always choose is an inhaled steroid. In COPD, it's not. In COPD, we choose the long-acting bronchodilator medications. And that is well shown in multiple studies that that's the appropriate sequence in which to do it. Now, as they get more severe, and they get under 50%, you really have to decide on that individual person, are they having a lot of exacerbations? How symptomatic are they on the course of a day-to-day basis? If they are having frequent exacerbations, flare-ups in their disease, you want to add in an inhaled steroid. That's really the biggest role for inhaled steroids in COPD. And as they continue to get worse, realize that all these medications can be used together. You can use two different kinds of long-acting bronchodilators. You can use an inhaled steroid. All of these things put together add up to the right therapy for the individual patient.
It's pretty exciting lately that we have a bunch of options now for how to treat COPD, as opposed to several years ago when all we could use really was inhaled bronchodilators, sometimes with the addition of anti-inflammatory inhaled steroids. Now we've learned that inhaled steroids really should be targeted to individuals who have recurrent exacerbations of COPD or flare-ups of their disease. Sometimes also with chronic bronchitic symptoms, inhaled steroids should be beneficial, or in people who have a COPD and asthma overlap syndrome. In people who really just have breathlessness, we can maximize inhaled bronchodilators. So we can use long-acting beta agonists and long-acting antimuscarinic agents, but spare them the inhaled steroids, saving steroids for people who have recurrent exacerbations. In addition, that group of people who has recurrent exacerbations, there are newer therapies available, such as PDE4 inhibitors, roflumilast being the one that's approved in the United States, which has a pretty large benefit in reducing exacerbations, as does the use of chronic antibiotic use with azithromycin.
Never forget about oxygen therapy as well, because oxygen is a therapy. If somebody has low oxygen levels, we're not just prescribing it so that, well, they'll feel a little bit better. Certainly we hope that they feel better, but it also is good just for the physiology of the lungs and the whole body.
The other specific therapy we can offer in what we call phenotype-directed care is people with upper lobe predominant emphysema who have low exercise capacity. We can offer them lung volume reduction surgery, which turns out to be the only therapy other than oxygen which improves COPD mortality and is an important therapy to offer in specific populations.